I'd like to warmly invite our panel members to come up. I start with Marie Thiessen, who is not Doug Hilton. She's very, very kind. Doug is unwell, so Marie Thiessen has agreed to... Yeah, who has agreed to stand in. Michael Kidd, who is here. Welcome, Michael. And Kamalini Lokuge. Mike, don't sit on the mic. Okay, all right. The topic for this panel is about the strength of social licence and how and the factors that increase that and decrease that. Voltaire, the great European 18th century thinker, said that those who can make you believe absurdities can make you commit atrocities. And I think the previous panel shows just how powerful that statement is, that there are many absurdities and beliefs that underpin many atrocities that have been committed. And I think we can all also acknowledge that there will be many things that people will look back in hundreds of years at what we are doing now and question them. So it's I think we all need to come from a place of humility. The statement also not only talks about the relationship of belief to action, but it also speaks about power. It says those who can make you believe absurdities can make you commit atrocities. So not only is it that our beliefs affect our actions, but also that there is power behind how those beliefs are generated. We've had major shifts in our thinking over the previous couple of centuries. If you imagine the many thousands of years of European, particularly, medical medicine, it was largely ineffective until the last couple of hundred years when we basically learned to count, but also to use evidence and to take action in the face of that evidence. And key to taking action and to generating the evidence is a partnership with community. We can't do research without community. We can't have action on health without community. And underpinning that action with community is often talked about as the concept of social licence. So that is why we are here right now. I'd like to introduce our esteemed panel. We also send our warm wishes to Doug Hilton, who's unwell, and our profound gratitude to Marie Thiessen for stepping in at this point. Marie is the director of the Matilda Centre and an NHMRC Leadership Fellow at the University of Sydney. She's chair of Australia's Mental Health Think Tank and a former National Mental Health Commissioner. She's made major contributions to Australia's health and medical research effort, particularly in the field of mental health and substance use. And in particular, she's known for her research on comorbidity between mental health and substance use disorders. So incredibly well placed to talk about social licence. Michael Kidd almost needs no introduction. He is Australia's Chief Medical Officer and has extensive experience as a frontline general practitioner, primary care researcher, educator and academic. He's also been the Professor of Global Primary Care and Future Health Systems at the University of Oxford and Director of the International Centre for Future Health Systems at the University of New South Wales. And Professor Kamalini Lokuge, who's already been mentioned by Norman Swan earlier. She leads the Humanitarian Health Research Initiative at the Australian National University. She and her team conduct operational research in essentially crisis settings mostly, would you say? Yeah. In partnership with communities and service providers to provide effective health service delivery and prevention in those crisis settings. She's a public health physician and an epidemiologist and has worked long-term for Médecins Sans Frontières, the World Health Organization and the International Committee of the Red Cross in a range of humanitarian emergencies. She's also known for her work with state and federal governments on their response to COVID-19 against a background of having repeatedly controlled high-risk pandemics. So I'd like you to join me in welcoming our panel. So my first question, we really wanted to make, we knew that by this time in the day, after lunch, after that incredible panel that we just heard, people could be feeling quite overloaded but also, in a sense, really trying to process what they specifically can do and what the role of themselves and their institutions might be. So we thought we might make this session as much as possible practical and solutions focused. And I'd like you to hold us accountable for that. So on that note, I'd like to ask you, Marie, what is social licence?
Okay, thank you so much, Emily. So you've already mentioned that I'm a drug and alcohol and mental health researcher, and that particularly the drug and alcohol, I do love a pub trivia game. So we're all going to play a pub trivia game. So everyone up on your feet. Up. All right, that means you're all off your phones, so excited about that. No one's doing their emails. All right, now, this game is, I'm going to ask you a question, and for you, if the answer is yes, you're going to put your hands on your head. Practice that. Put your hands on the head. Oh, look at that. I've almost got 100%. There's someone with their hands up. What are you doing? Hands in your pocket. All right, next. If the answer is no, you're going to put your hands on your bum. You know where your bum is? Everyone got your bum? Right, bum. Oh, let's not put your hands on your bum. Practice, 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 practice. Okay. All right, the first one's going to be an easy warm-up question. Okay. I absolutely am passionate about medical and health research. Yes, hands on your head. Oh, good, 100%. Okay, we're doing well, we're doing. Didn't keep it up long enough, Graham. Come up on your head. Okay, all right, hands down, hands down. Shake them off. All right, first question. Okay. All right, this one's about social licence. In the last 12 months, I'm going to make it easy for you, have you spoken to anyone in your stakeholder group about your research? Anyone? Come on, it can be your patients, it can be someone at the school, it can be your kid, if you like. Oh, good, Ben, I got you on your child. Been speaking to your child. Okay, well done. And a no is hands on your bottom, okay? Okay, those no's, sit down on your seat. All right. Okay. Sorry? No judgment, no judgment, Michael, no judgment. She's not in the denominator, no judgment. Okay, you can take your hands off your head now, people. We're going to do another one. All right. And who, in the last 12 months, has listened to someone about any research? That can be in the media, but it can be, oh my God, look at the amount of social licence that's happening in this place, Emily. That is incredible. Anyone with their hands on the bottom, sit in your seat. No? Okay. Now this one, because social licence isn't just about talking about to your friends and talking, it's also talking to those in power and those who are going to be making decisions. So, hands on your head, yes, bum, no. Who in the last 12 months has talked to someone, either a bureaucrat, a policy maker, or a minister about their research? Hands on your head. Those who've got their hands on the bottom said, incredible. This, to me, it is almost everybody. One last one, I'm going to try and press you a little bit more now, sorry. Hands on your head, bottom. Who has spoken to actually the health minister or the education minister about their research in the last 12 months? Oh my God. Okay. Everyone else, don't sit down yet. Everyone else, sit down if you put your hands on your bottoms. Stand up if you've got your hands on your head. Stand up. And everyone else is going to come and find you at afternoon tea, and they're going to get your number, and you're going to introduce them to whichever minister they spoke to. Thank you, everyone. Sit down. But I am absolutely so impressed with how much social licence is in this room. And I actually, when I looked at this question, when you asked me to speak, I was so excited to talk about it, Emily, because I actually think the social licence for health and medical research in Australia is incredibly strong. It doesn't mean that we don't have some massive threats on the horizon, but right at the moment, it is incredibly strong. And that's what I would like to hold on to, and which I think, being this incredible academy, can allow us to supercharge. So thanks for asking, Emily.
Well, thank you very much, Marie, for that very hands-on explanation of social licence. Sorry about that.
Puns are going to keep coming.
So, Michael, thanks so much for joining us. Can you perhaps talk to us about what you consider the basis for social licence for health and medical research in Australia and internationally is?
Yeah, thank you, Emily, and hard act to follow, Marie. I'm not going to make you stand up, so just relax. So what is the basis? You know, I thought it was really interesting that in this room, the social licence is very strong. How strong is the social licence outside of this room? And do most people actually think of us and what we're doing, or are we somewhat taken for granted? During the COVID-19 pandemic, of course, many of you were elevated into public figures to talk about the science and talk about what was happening. But the public's largely forgotten much of that since that time, and many of us have faded somewhat into the background yet again. However, I went and looked at the Ipsos survey of who Australians trust the most, the professions which are trusted the most. And, you know, you might like to write down who do you think was at the top of the list and who were in the top 5 and who are in the bottom 5. So let's look at the top 5. Who are the people who are trusted the most by people in Australia? Doctors and nurses and other health professionals. No surprise there at all. Teachers, educators, which of course includes many of us, particularly at the higher education level. Scientists, which includes everybody in this room. Pharmacists, all of us have a relationship with a pharmacist. And the 5th group is the frontline emergency workers. Excuse me, our ambulance officers, our fire people and everyone. Oh, thank you. Dr. Marie. Thank you very much. Right, okay, good, still there. So who's at the bottom of the list? The very bottom group, I'm not sure if any of you would have this, but think about who do you think is at the bottom, the least trusted people in Australia? Social media influencers. Did anyone have that on your list? The least trusted group in Australia is social media influencers, which I find absolutely fascinating because they're supposed to be the reverse. They're supposed to be influencing us, but people don't trust the social media influencers. The second bottom group, I'm not sure I'm allowed to say in this hallowed building that we're in at the moment, where so many amazing Australians have had their lunch in the past, but it's our politicians, our policy makers, public servants and others are not trusted a lot by people in Australia, no matter how hard we try. And then it's advertising executives, real estate agents and, surprisingly, journalists are not terribly trusted either. So they're the groups. So you look at the two. So we're very high when it comes to the social licence, but I think we take a lot of it for granted. I think that the social licence is based on people trusting that wise people around the country are doing the best for everybody. I don't think people talk about our ethics very much. I think that's just a given. I don't think people talk a lot about our systems of regulation and ensuring safety and so forth. I think that, again, is just a given, but they're very important parts of that social licence.
Thank you so much, Michael. Kamalini, I've often heard you say that really central to social licence is that people experience benefit from what you're doing. And if you are going to do research, you need to make sure that you are being of direct benefit. And I'm just wondering if you could expand on that and let us know about your experiences at the front line with conducting some of the most difficult research that I've ever seen. In fact, I have supervised Kamalini, and I would often have to sort of elevate her travel sign-offs to the dean, and he would come back and say, "What is this? Pick a war zone? Any war zone?" So, you know, Kamalini is one of the people who's really put her life on the line for a lot of the work that she does.
Thanks, Emily. So I think I want to quickly go back to what the other two panellists said, and I think related to something that was said in the previous panel. My experience is that trust or social license is based on a lifetime of experiences. So it's not about what you say to someone at that point of where you need them to trust you. It's what they see you as embodying. So what if you try and put yourself in their shoes, you'll see whether they're going to trust you or not. What do they see when they look at you? So as the previous panel said, if they look at you and see someone who their grandmother or their mother has told them stories about what was done to them as a child, they're not going to trust you. But if they see you as someone who's been there when they've been sick, who's been there for their parents, for their family when it's sick, they will trust you. And the experience of mainstream Australia, early on in COVID, I said, they will do what we need them to do, because their experience, largely mainstream Australia, has been, I have Medicare, I can see a doctor, I can educate my children, the garbage gets picked up, my letters get delivered. That's the experience of mainstream Australia. And Michael knows, I said very early on, that's not where your fight's going to be. It's going to be all the people who either have come to this country with a history, generations of fear of authority, or people, all the communities here whose experience has been harassment by police, has been a health system that marginalises, stigmatises and doesn't give them what they want. They're the people that you're going to have to reach out to. And when I said early on that the challenge is not going to be the next vaccine, it's not going to be, the diagnostic test. The challenge is going to be, how do we get those people whose experience is different to the vast majority of Australia to engage in everything we need them to engage with? And early on when I said that, nobody understood. They said, what? What are you talking about? And as time went, and I remember saying, people don't understand trust. They don't understand partnership now, except if they've worked with Indigenous communities, if they've worked with drug and alcohol populations, if they've worked with refugees, they will know. But what I saw is this transition, and when the people in decision-making power got to a point where they thought the disease would kill them, would make them sick, or even would mean that there was nothing on the shelves in Woolies, then they started to think, all right, how? Maybe we need to reach out to these communities. And real change happens. I've worked with many high-risk pathogens, and the one good thing about that is the people in power start to worry about their lives, about their families' lives. And then they, for a period, give up power. They hand it over to the people who should have it, who should be implementing programs, so that the problem gets fixed. But as soon as it's over, we go back to where we were. And what I would say, Emily, is, I've told Michael, I remember telling everyone, there's this small window of opportunity to make a difference, and it closes quickly. And the risk is that things will go back to where they were or worse. And I think people here, I'm sorry I haven't directly answered your question, but I don't want you to go away thinking that because largely we do a great job for the majority, that we're doing a good job. We're not. We're not for those who most need our help. I'll stop here.
Thanks so much, Kamalini. So, Marie, what do you consider are the things that build social licence, and what do you see as the things that compromise social licence?
Okay, can I start with the compromise, Emily? I was very fortunate actually to be at the honorary doctorate award of Julia Gillard last week, and it was incredible to be there. And she spoke very, very strongly of what she saw as three threats, basically. and world trends that we would really need to be on top of if we were thinking about our social licence. And that was from an education and from an academic, but also from a medical research perspective. And the big three, if I can bring them up, were first the incredible rise of very ultra-rich individuals and their power base, and how we would deal with that as a society. The second was the growth across the world, but particularly in the US, of the authoritarian regimes that are happening, and effectively the social licence that Trump has. And he's completely flipped on the head what social licence means. It's like, social licence to do what? And no one in this room would be very happy about the licence that the social things that he wants to do with his licence. So that was the second one. And the third one for her particularly was the way that we are obliterating what has happened in gender equality in the world. And that's being driven across the world. So if I think about what are the three big threats that we need to be thinking about as health and medical researchers, I sat there with goosebumps thinking they are enormous for us to challenge. So what are some positives in response to that so that we don't leave ourselves very, very unhappy in the room here? This isn't the first time the world has experienced these types of things. I actually think Australia's got some incredible strengths that are quite unique to us. We heard that a little bit this morning, people talking about what is unique to Australia. I think education is a big one. Our universities are not based on just letting the elite in. They're actually, and our medical research isn't as well. This academy isn't built on just, whether you're a lord or in the UK or whether you know someone. It's built on equality and equity and being able to be here regardless of your social class. It doesn't matter that I was first in family to go to university. I'm sure there's a lot in the room who were that. You can still be in the academy. So that is an incredible strength of our community. We also were the first in the world to let women in very early on. I think we beat Oxford by 100 years. Australia beat Oxford University by 100 years, letting women in to university. How incredible is that? So for me, that's what will be the thing that we should lean into. So things like the academy and things like education, and that also means our young people. And they're 30% of the population, 100% of our future. They're the most educated group ever. In that cohort of adolescents. How do we lean into that and make that work for social licence? And look at where our strengths will be. I'll stop talking in a minute. But Emily and I, you and I have been up against big tobacco. My gosh, the vitriol that we cop from big tobacco. We've been up against big alcohol. And I sort of feel like we've got a lot of learnings in this country, and we took them on and taken them on over and over again. And now we're seeing the rise of the anti-vaxxers, and I think it's the same group, same methods. They're probably all the same people. Australia has some incredible ability to tackle, big tobacco and big vaping, which is also big tobacco. Let's learn from those things and show the world how we can do it. Over to you, Michael.
Thanks, Marie. No, in fact, I was about to say, so Michael, you have, what I think is interesting reading out your bio is that you do have many hats. You think you have the general practitioner, you are chief medical officer, you're also a researcher. From those different vantage points, pick all of them or any one of them, what do you consider builds and compromises social licence for health and medical research?
Yeah, so I think we're getting to the crux of this whole issue, and what builds the social licence is trust. It's the trust that people have in us, and that's why those groups that you see at the top of the of the table, our health professionals, our scientists, our teachers, our educators, our first-line responders. These are people who trust us, or who are trusted. And what breaks that down is when that trust is breached. Now, that can be breached for a number of reasons. You know, as individual health professionals, those of you who are health professionals, you know that your integrity is everything. And if your integrity is called into question, then people may not trust you. You know, I experienced this as a young GP working in a small rural town. I had to be careful to practice what I preached. I ended up changing the supermarket I went to. I'd drive to another town to go to the supermarket because people would be looking in my trolley, seeing what I was buying and seeing if there were things that I told them they couldn't eat in my trolley. I went to the pub once in my town and drank too much and got a bit noisy. Never again, never again. And I remember vividly being strips were torn off me by a 5-year-old patient who came in and said, "My mum and I were walking down the street the other day and we saw you run across the road. You should be crossing at the traffic lights." So people are watching us. Now they're light-hearted, but people are watching us. They're watching to see what we're doing. They're listening to hear what we say. You know, every time a microphone is put in front of one of us, as one of the leading health and medical researchers in the country, people are listening to what we say and are ready to tackle that if they don't believe what we say. So we've got to be very careful. The other thing is, and Marie, you were alluding to this, and so was Kamalini, is the incredible pressure that we're under. And, you know, social fabric is really important, but social fabric can be torn. And we're seeing social fabric being torn. And this is leading to the rise of misinformation and disinformation about things that we all know are true and believe in. And some of that is generated by those who feel disempowered, who don't feel that they're represented, who don't feel that they're included. Kamalini was my teacher during 2020 and the COVID-19 pandemic. We went through the first lockdown. Do you remember the first lockdown where everything closed in the country? And then almost immediately afterwards in Singapore, they had a second lockdown because of the Singapore dormitories out at Changi Airport. They hadn't thought about getting health messages and out to the migrant workers who supported the whole country. And we were on the National Committee together talking about, well, where will Australia's Singapore dormitories be? And Kamalini listed out all the places that she thought would be the areas of vulnerability. And then the second wave started in Australia, and all the places that you'd predicted and all the populations that you predicted, which included non-English-speaking background populations, new migrants, people who are living in poverty, people who are homeless and others. This is where things happen. So, you know, we need to be aware, but we need to be bringing everyone in. And at a time when diversity and inclusion are becoming forbidden words in some parts of the world, it's incredibly worrying. Because, you know, this has to be at the heart of what we're doing to make sure our social licence remains very strong.
Thanks so much, Michael. And Kamalini.
I think the previous panel pretty clearly outlined what destroys social licence and trust. So I'll talk a bit about my experiences of what builds trust, and what every day in my work I'm amazed by is how you can build trust with people who have, you know, had experiences that you think they'll never trust anybody again. And a lot of what I was able to contribute to COVID was based on the work I did overseas. And I'd been working on Ebola for a long time when West Africa happened, and early on in Freetown, I had a patient who came and he tested positive, and he wasn't linked to any cases we knew of. So I knew there was transmission I needed to look at. So I went to visit his family, and there was a whole lot of things I did that meant I could engage or work with them effectively. So when I was coming from the airport in a Land Cruiser, white Land Cruiser, I heard as we were driving through the airport, that first hour I was there, equipe Ebola. So I knew that white Land Cruisers to the community meant Ebola teams. So I got special permission and hired an old beat-up blue pickup. Because that's what all the gangs, all the tactical groups were driving. And I knew if I went to a house in an old blue pickup, it wouldn't communicate to the entire village that that household had Ebola. Even before I landed, I didn't go with WHO, I didn't go with any other organisation except Médecins Sans Frontières. And that was because the experience of people with MSF was these are the people who come. When there is war and I need help delivering my baby, they will be there for me. So I've already, I'm way ahead of a lot of the people who are coming to do investigations in those settings. I took this incredible anthropologist I'd worked with before called Julienne Anoko. She was from Cameroon, and she has this almost magical ability to build connections. So I just sit there while Julienne talks, and so we arrived at this family. They were very angry, but they still opened the door because we hadn't, even before we arrived, stigmatised them. And we sat and talked for 2 hours, and you would think 2 hours about filoviruses and hand hygiene. No, it was, who are you? How much are you getting paid for being here? So I talked about I was a volunteer. I came because I had done this work before and I have something I think I can contribute working alongside you in your community. Why did your mother send you here? And I said, my mother is scared. She doesn't want me to come, but she knows I have something that can contribute, and that's why I'm here. So 90% of the time was the discussion about who I was and why I was there. And once they knew who I was, and again, the previous panel said it's relational. It's not, so this is a filovirus and this is how it transmits. They weren't interested in that. After that 2 hours, when they thought, we know this person, we know her mother, we know where she comes from and why she's here, they brought out a sick young man who they'd been hiding for a week. He tested positive. That afternoon, they brought to our treatment centre 2 more sick young men who they had been hiding. So that is, I'm not good at conceptual stuff. That's my experience. You can build trust in the most complex, challenging circumstances, but that requires building on a history of trust. You can't just turn up and say, trust me, I know what I'm doing, do this, hand over your relatives to almost certain death. I'll do what I think is best. You cannot do that. You have to work with those who have already built a legacy of trust, and you have to find a way to build a relationship.
Thanks so much, Kamalini. I think one of the things that has come through very strongly from all of the discussions is that in order to build trust, we need to be inclusive about who is actually conducting the research. And we need to make sure that the research that we are doing is conducted in partnership where the people who live the problem are in power. And in some ways this actually means ceding some of the power that I think scientists have been used to for a very long time. So it's about having partnerships where if your community and lived experience people say, we don't want you to do that, we think you should do it this way, that is truly a partnership in how things are conducted. So I'm quite interested in the last few minutes just for getting an indication from our panel members about ways in which you see that power dynamic in people who are who've been called the subjects of research and actually are increasingly being brought in as partners. What is your experience of ceding power?
Is the MJA person here still?
Yeah. Ginny.
I think it's a complicated journey, the ceding power. I find it challenging. But one thing that we did just recently, and it's published in the MJA, was to look at how to seed that power to young people particularly. So it was a review of the literature, how to do that in a way that was psychologically safe for young people, to have them involved in research, but then also have that piece of work led by young people. And that was in a special issue. So I think that was just an incredibly important, the most prestigious medical journal in the country, allowing a young person to be first author on that paper with the guidance of the research team and develop from the beginning. So for me, that was confronting every step along that way, but incredibly powerful. And then that was picked up, interestingly, by industry, most by industry. Not by our medical research collaborators, but industry wanted to know how to engage with young people and the stakeholders. I'm slightly worried about which industries, because then they're gaining social license from what we're doing, probably hopefully not Trump. But yeah, that was it. But it's difficult to do. And can I just say, as I hear you all talk, I can't help myself, but I put on my hat like, I've got 5 grants to review tomorrow for MRFF, thank you very much, and I've got a ton of work to do, and how do I carve out time to do this extra work, which is, it shouldn't feel like extra work doing the social licence, but it does, and then how do I talk to my staff about doing that, and then how do I fix the system so when they go for promotion they're not disadvantaged because they put this extra work in to doing this, which I think should be our core work, but it isn't. So I just wanted to shout that out, that even me, who really cares about social licence, was sitting here today going, I don't know how I'm going to have time to do as much as I want to do. Yeah.
I don't think it's a matter of whether we might get that strong consumer voice into the work that we're doing and all the work that we're doing. It's an imperative. And Doug's not here, but I'm not sure how many of you have seen the recent report that CSIRO and New South Wales Health did, looking at the megatrends that are affecting health systems in Australia and around the world that we need to be preparing for. It's a fantastic report, it's very brief, and it talks about limitless care, the move towards being able to deliver care remotely, telehealth and so forth. It talks about precision medicine and the revolution in genomics that we're riding at the moment. It talks about augmented care, use of AI, robotics and other technology in what we do. It talks about the volatile world we live in, the external factors that we may not be able to have as much of an influence on, but which are having an impact. And then the 5th group is the empowered community and the expectations of consumers of our services, and how this has changed with the rise of social media, with the internet. I remember one of my dear colleagues, the late great Branko Chesnik, saying the internet is the greatest collection of misinformation the world has ever known. That was 25 years ago, and of course it's just got bigger and bigger and bigger. So social media is having an impact, but then the pandemic had an impact. Everyone became an armchair epidemiologist, Emily, and an expert in the field, and then immediately forgot everything over the last couple of years, leading the epidemiologists to do their work. But the expectation there is still there, and much higher than it's ever been before. And so, I encourage everyone to think about, are we paying lip service when we're putting together panels of consumers to help us with our research, or are we really empowering that voice to influence the work that we're doing right from the outset with the research question, developing the proposal? My most recent MRFF grant, I'm not allowed to apply for them now that I've become CMO, but I did get one just beforehand. We developed in partnership with the Consumers Health Forum around multidisciplinary team-based care and primary care, because we wanted that voice to be really strong and to have real ownership. And that included a significant amount of the funding going to support the consumer organisations who we want to work with in the research we're doing.
Kamalini.
So, how to seed power? Hey, Emily. So, I have a really good, easy way for me of doing that. I think I sit and think, I want to do some work. Is the team I'm supporting to do that work, does that team look like the community that I'm going to be working with? And if it doesn't, then I know that power has not been seeded. And the NHMRC Health and Medical Research Strategy came out recently, and I think there is a recognition about seeding power in Indigenous health. As we heard from the previous panel, there's a recognition, but we've got a long way to go. That recognition hasn't even happened for other populations. Like, there's a little box in one section of the strategy that says, account for priority populations. I mean, what does that mean, account for priority? So we know what to do, and we'll stick them in a box that says we're accounting for them. And in my view, so I think there's a long way to go. But what I would... I did this work on the front line for a while. I didn't want to get on a plane and go to Ebola across the world. Every time I got on, I think, why the F am I going? Why isn't someone else going? So after a while, I said to the organisations I work with, if you don't stick a young person on the plane to meet me and to take over from me, I'm not coming. And from that experience, I thought, here's someone who's way better than me and will be around for the next 50 years doing this work. I thought, I'm going to try and do that for my research. And like at the moment, I have a student in the field doing work on person-centred care in war zones in Amhara region in Ethiopia. He was born in Amhara, and he is doing this research, and it's incredible. And more than anything, I just get such joy from it. I can grow my tomatoes. Every now and then I say, you're doing a great job, keep going. And I feel like my impact has amplified. The work that's been done by us is far more effective. And to me, there's just no downside. But it does require at some point shifting from... and it's funny, me being on this panel, I only said yes because of Emily. I don't go to conferences anymore. I don't go to panels because that's their job now, young ones, to get out there, to sell their story. Literally, I grow tomatoes and I support them. So to me, that's what seeding power looks like. Emily?
Okay, so thank you very much, Kamalini, and I think that's a great note for me to hand over to the audience, to cede power to the audience, and see if you have any questions for the panel. Got a microphone?
Oh, yeah. Thanks, Catherine. Lady, go first.
Is this on? Yes. I'm Diane Nicol. Thanks, panel. That was a really great discussion. And Kamalini, I'm glad you left your tomatoes alone. I left my tomatoes too, to be here. It was a great discussion on social licence, and I think I'm beginning to understand what it is a bit more. But as perhaps the only lawyer in the room, what interests me, of course, is words and what words mean, how you define words. And I'm not quite sure I can really define what social licence is. So my question to you is, what does social licence mean to you? And who do you need licence from to say you've got social licence?
So who would like to answer that?
Marie, go. You put your hand up.
Did I?
Oh no, maybe you didn't mean to.
I did not put my hand up. I'm being bullied by the panel. Can't bounce the question.
Well, yeah, how would you define social licence?
Come on. You're the lawyer. Give it a go.
Lawyers ask questions.
Yes, I'm asking it back. I'm asking it back.
Lost the microphone.
Lost the microphone. I'm asking it back. Bounce it back.
I think you're on the spot.
Thank you. That wasn't what was intended at all. I think I said at the start in a question to Joan that I see social licence as being very different from trust. So social licence to me is having the, I guess the permission from the group that's going to be most affected by your decision to do something to actually feel that you can go ahead and do it with some confidence. But to me, social license has to be an ongoing thing. It can't just be something which I think could be done where you just tick the box and say, well, we've got our social license, we can press ahead. So just as trust is an evolving relationship, so too social license has to be an evolving relationship. So it's that relationship between the person who is undertaking the research, and I think it has to be the community that's most affected by that research, because you couldn't possibly have license from society as a whole, because we've all got different views on things. But yeah, to me it's really tricky to nail exactly what we mean by it. We sort of bandy it around, but I don't know.
To me,
Fourth person.
this social license entirely depends on trust. And trust is hard won and very easily lost. So every single thing you do needs to be founded on trust. Otherwise, you lose your social license. And I think I did start with that I think the way I try and look at it is I try and put myself in someone's shoes, the community I'm working with, and say, if they look at me, what are they going to see? Based on their past experiences of who I look like, who I've come with, are they going to see me as someone who might bring benefit, who might walk alongside them and support them, or someone who's going to exploit them and make use of them? And I think, so that's how I think the two are related. You know, you can't have one without the other. And to me, that's a simple test of it. And like I said again, I'm continuously amazed by how people that should have no reason to trust, somehow you can forge a relationship that, if you work hard and come with the right, I guess, the right way of thinking and working, and you're prepared to cede power, you can build trust.
I think that was a very good example of a great outcome with ceding power. That was a very good answer, Diane. Thank you. So do we have any other questions?
Can I ask a question? Hi, I'm Guy Marks. I'm never quite sure how to describe where I come from, but I'm at the Burnett and I'm living in Katoomba, so you can work it out from there. So I found this conversation very interesting and challenging, and I find myself quite concerned about this concept of social licence. And I go back to what you quoted from Julia Gillard, that there have been a lot of bad things happen and continuing to happen, apparently with social licence. You know, we heard, you know, about the massacres of Indigenous people in Australia, which happened with social licence. Slavery happened with social licence. The Nazi regime in Germany happened with social licence, in one sense. So it's not. It seems to me we're not trying to give, and as Julia Gillard apparently alluded to, Donald Trump and J.D. Vance and RFK Jr. seem to be operating with some form of social licence to do dreadful things, terrible, terrible things. So we're not trying to enable that. What we're trying to enable is evidence-based and humanitarian, humane actions to be taken. And I think perhaps what we need, and also social license, bad actors will act to remove social license. J.D. Vance said the worst people in the world are experts. That's something along those lines. The worst people in the world. What's his name? The former head of the National Institute of Allergy and Infectious Diseases, Fauci, has been vilified who is to many of us a hero, has been vilified by people around the world. So it's a contested space, and we need to understand why this is a contested space, and we need to make sure that the good guys, if you like, and women, get control of that contested space, and the bad guys, who there's no doubt about who they are, don't get control of that space. And one could recount a whole lot of situations. So I guess it's a comment really, but I'm interested in the view of the panel about that context.
Thanks so much, Guy. Can I question one thing, which is, I think in those situations, the people who were most affected were not empowered. So in the case of the massacres of Aboriginal people, the people who were most affected were the Aboriginal communities. And in that situation, there was no social licence for massacring them. I'm sure the Jewish people did not give a social licence for the Holocaust. So I'm not...
But the people who are implementing it.
Well, that's where I think what we're saying here is social licence isn't the majority of people thinking it's okay. Am I right there, panel?
Exactly. I think it's conflating the rule of the majority with saying, and I think, again, if you go back to that thing, if the person who is in front of me, I'm asking to do something or engage with something, looks at me and sees someone who's perpetrated genocide on their community, they're not going to give me a social licence to do what I want. I think, and Donald Trump, I'm sure you've seen Hispanic people on TV saying, we voted for him, we didn't realise he was going to do this. He doesn't have a social licence for what he's doing, but I think if in the way I see social licence, but I'll hand over to the rest of the panel.
We do have to wind up, I'm afraid. We're running a bit over time, but maybe one more comment. And I'm sorry about the other question. I think Graham's looking at me funny.
He is. For me, there's huge power in this room, and it's the power that each of you have as respected health and medical scientists in this country, and using that power for good, using that power to talk about the sort of abuses that you're referencing, Guy, using that power to support and empower the people who don't have the voices that we're privileged to have. So for those of you who are new fellows, and congratulations to all the new fellows in the room, this is part of your task as well now.
Thank you so much. And please join with me in thanking our panel and our empowered members of the audience.